Welcome to this edition of AFMC.
I'll tell you how I got better. I'm
Glad to be here.
But a mission to
Delivery of. Well, I think that we're going to talk about everybody's.
Arkansas is the second highest prescriber.
Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Bo Ryall, and he is the Arkansas Hospitals Association President and CEO. Thanks for joining us.
Thank you for having me, Robin. Appreciate it.
Tell us about the Arkansas Hospitals Association. What is it?
So all the hospitals in Arkansas are members, so it's 105 member hospitals. And so that could be your traditional hospital, like an acute care hospital. It could be a long-term acute care, rehabilitation hospitals, psychiatric hospitals, and we do have a hospice member. So we've got a wide range of healthcare facilities that we represent.
And what are the main ways that the organization supports them?
So advocacy and government relations. So we work with state and federal legislators and government agencies as far as shaping regulations and laws that are helpful to hospitals and helpful to patient care. So it improves patient care, but also the financial viability of hospitals because we depended on Medicare and Medicaid for payments. We also communicate that to our members because there's so many myriad of laws and regulations that govern healthcare and hospitals. So we want to get that out to our members and have so they know exactly what's changing because it changes daily. And then we do education for not only the CEOs, CFOs, COOs of an organization of a hospital, but also the people who work in hospitals. So the nurses, we do continuing education there, and you wouldn't think, but the engineers need continuing education, the human resources, the purchasing agents. So we've got a lot of different groups that we provide continuing education to. And then also we're not new, but somewhat new is a data program that we're working on for hospitals. So throughout my career, I've thought it interesting that researchers and policymakers think that hospitals are this huge data repository and they can just ask for something and we can just provide it to them. Well, that's not really true for hospitals. So we've been gathering information for years as far as a hospital and patient records, but to be able to provide that in a way that's useful to hospitals and researchers and policymakers, that's kind of new for us. So we have a data program that we can provide data back to hospitals so that they can look at patient care and how to improve patient care. Also, the financial viability of some services. So they could look at a service line and say, well, this is really working for our hospital. We need to expand it or we need to move on from it. So we also have a quality program that we've got 3 nurses who work on our team. So working on that.
And not many people know about the quality program and it's in patient safety initiatives that hospitals are engaged in. It's a lot of work.
Yes, it is. Yes, it is. So as I said, we've got 3 nurses who work on our team. We've been servicing federal government contracts since 2012. So we're working on reducing hospital-acquired conditions. We're working on reducing readmissions to hospitals. So there's big movement from the federal government to do those things, and we want to do those things and help out. So we've partnered with the Arkansas Foundation for Medical Care on some of those contracts and the Texas Medical Foundation. So I think what's good for us to see is the different forums that we create. So not only are we the boots on the ground talking to hospitals and their quality teams, but providing a forum for them to get together and to hear best practices that we think work, but then also for the hospitals to say, wait a minute, we've tried that in our hospital. This is what works best for us. Maybe you should try this to deal with a different type of infection or falls or to help with readmission. So those things are helpful, but also we've created recently a patient and family engagement council. So obviously we're bringing in former patients and family members to hear their experience in a hospital healthcare setting so that we can learn from that and provide that experience back to hospitals. So in thinking about how all of this affects our advocacy part, knowing that what works and what doesn't work in a hospital. So policymakers, government regulators, government agencies, they're passing all these regulations and laws, and sometimes they can be duplicative. Sometimes they can be, we're spending more time on paperwork than working at the bedside. So a big goal is to try to reduce all that paperwork and all those regulations in a way that it improves patient care, but also keeps the healthcare provider at the bedside and working, not just filling out paperwork.
And there has been a lot of talk in the news about hospitals closing or limiting services. Are you seeing that? I mean, what is the cause of it, and are you seeing that?
Yeah. So I guess we all had this line of pre-pandemic, post-pandemic. So pre-pandemic, Arkansas was one of the first states, particularly in the South, to take advantage of the Affordable Care Act and the additional health insurance that's available through Medicaid. So over time, we've had 250,000 to 300,000 people take advantage and be a part of this Medicaid expanded healthcare coverage. So two parts. So it helps the patient have better health care. But the second part is patients went from 250,000 to 300,000 uninsured to insured. So the hospitals and the doctors are now getting paid for those services. So what we've seen in other states that didn't take advantage of this, they've seen hospital closures, over 100 in the southern area. But Arkansas has not seen any of those closures because of that. So then we go through the pandemic, and hospitals provided all kinds of services, equipment to try to help people during COVID and to service those patients. We did get reimbursement for the government for some of those services, but as we left the pandemic, we saw inflation, supplies go up 20%, labor costs go up 30%, pharmaceutical costs go up 20%. So you're looking at costs going way up here, but reimbursement is still down here. So we're not like other industries, say a restaurant, where we can just raise prices to meet cost. For hospitals, we're paid by Medicare and Medicaid, which Medicaid has been flat in their payments. Medicare has gone up a couple of percentage points, but not enough to keep up with inflation. So now we're to commercial insurance, which those are private contracts that are negotiated. And I think what we're seeing now is that pressure from no increases from Medicaid and Medicare or limited increases has put more pressure on those commercial insurance contract negotiations. So you might have seen in the news where a particular hospital has gone out of network with a insurance company. So they're in negotiations, and those negotiations are more public than we've ever seen. So there's a pressure there as far as reimbursement, and it's really the pressure of making hospitals financially viable during this time, because it is really a tough time because of inflation.
And are you seeing that in rural areas specifically in the state?
Yes, we are. We've seen a lot of, the rural areas are more dependent upon Medicare and Medicaid, so, and rather than private commercial insurance. So there's that pressure there of working with Medicare and Medicaid and providing a better rate.
And you talking about changes of care, are you going from where they become like a critical access facility, or to where that there's more of a wider range of care to where they're having to travel farther to get that critical care?
Well, I would say the risk of closure certainly provides that access to care concern. So if a hospital closes in a small town or a small county, then you're looking at maybe a 30, 45 minute, an hour drive to have access to a hospital or a physician. So that's a big concern with hospital closure. Also, when you think about a hospital closing, you think about, well, the patient care that's there that's going to be missed, but you also think about the economic impact. So in most communities, the hospital is the largest or the second largest employer. So having that in a community certainly means that the community is more viable, the community is more successful, the jobs are there, the income is there, so it really helps the community. But also when you think about economic development, so if a industry is looking at a community to move in, they certainly want to see a hospital there. They want to see healthcare facilities. So besides the patient care that a hospital provides, it's the economic development and economic impact on that community.
It trickles down in a lot of ways.
It certainly does.
Yeah. So are there any challenges that are unique or more severely felt by rural hospitals? I mean, you touched on that a little bit.
Yeah. Well, I would just say to add to that, small hospitals, when I talk to CEOs of a small hospital, they say how difficult it is because they have to know how to do everything. Mm-hmm. And the margin of error is so slim. And when you compare that to a large hospital system, if they make a mistake, certainly they can overcome that. But when you're in a small hospital and the profit margin is below or right on the line, if you make a mistake, that could certainly result in the closure of that hospital. So the same challenges are there. It's just so minute there for those small hospitals that they have to really pay attention to. And it's a tough job. There's no doubt about it.
And you mentioned workforce challenges being felt by all hospitals, but especially those rural hospitals. How do these obstacles inform your advocacy work?
Well, we learned a lot of things from the pandemic, but one thing we learned about workforce is that for salary and wages, it is difficult for Arkansas to compete and go out and go to Dallas and try to get nurses and physicians to come in here, mainly based on salary. Now, we provide other great things, but salary, it's hard to compete. So we have to find ways to get people interested in healthcare careers and get them in the pipeline. So we've seen that a report that we did last year showed that we're 9,000 nurses short. So that's hard to overcome. We can't go out there and just buy them and bring them in. And we saw that with the travel nurse industry, that was just too much. The costs are just way too prohibitive to do it that way. So we've got to, if you will, grow our own in Arkansas and grow our own in the community. So we've got to get to middle schools, junior highs, high schools, and talk about healthcare careers. And that is a great way to make a living. It's a great career. It's very satisfying, and it's a way to keep you in the community and keep you in the state of Arkansas, which we all love and want to stay here.
And what is a rural emergency hospital, and is the introduction of that designation a positive change or a negative for the state?
Well, I think it's a positive change. So the federal government made this available. So you mentioned critical access hospital. That's another small hospital designation. But a rural emergency hospital has been implemented in the last couple of years. And so instead of providing inpatient, outpatient, and emergency department care, a rural emergency hospital does not provide inpatient care anymore, but they provide outpatient and emergency department services. So what we've seen at the smallest of the small hospitals that are right on the line of staying open or closing, this is an option for them to pursue in their communities to have healthcare access available to them. I think it's a positive because we're not converting a hospital that's seeing 25 inpatients a day. No, we're converting one that has limited inpatients per day, and so it still provides the services to the community, and still is a hospital there in their community.
Well, thank you. Thank you for talking about this important information and sharing what the organization does. And I have no doubt that what the organization is doing is beneficial for Arkansans. Thank you.
Well, thank you, Robin. I appreciate it.
Yep. And that's it for this episode of AFMC TV. Thanks for watching and have a great day.